Artificial Intelligence Doctor. User question. How to manage the changes in the extracellular matrix composition and the stiffness that influence mechanotransduction signaling in prostatic cells during BPH development. ChatGPT. Thought about ECM changes in BPH for 6 seconds. Benign prostatic hyperplasia, BPH, is characterized not only by hyperproliferation of epithelial and stromal cells, but also by remodeling of the extracellular matrix, ECM. The altered ECM composition, e.g., increased collagen, changes in proteoglycans, and heightened tissue stiffness significantly influence mechanotransduction pathways in prostatic cells, thereby contributing to disease progression. Below are key strategies, both established and emerging, that aim to manage or modulate ECM changes and mechanotransduction signaling in BPH. 1. Pharmacological approaches. A. Targeting TGF-beta/SMAD signaling. Rationale. Transforming growth factor beta, TGF-beta, is a critical mediator of ECM production, e.g., collagen, fibronectin, and stromal cell activation, e.g., myofibroblast differentiation. Overactivation of TGF-beta signaling increases tissue stiffness and drives profibrotic changes in the prostate. Approach. Small molecule inhibitors of TGF-beta receptors or neutralizing antibodies against TGF-beta can reduce the fibrotic response, mitigating excessive ECM deposition and stiffness. Some of these agents are in preclinical or early clinical trials for fibrotic diseases, and future applications in BPH management are being explored. B. 5-alpha-reductase inhibitors, e.g., finasteride, dutasteride. Rationale. By blocking the conversion of testosterone to dihydrotestosterone, DHT, these agents not only shrink the epithelium and stromal compartments, but can also indirectly reduce stromal proliferation and ECM remodeling. Outcome. Clinical evidence shows a decrease in prostate volume over time and, anecdotally, an attenuation of excessive stromal and fibrotic changes. C. PDE5 inhibitors, e.g., tadalafil. Rationale. Phosphodiesterase 5, PDE5, inhibitors can improve blood flow and relax smooth muscle in the prostate. Some studies suggest that PDE5 inhibitors might also modulate the stromal microenvironment via the cGMP pathway, though the precise impact on ECM composition and stiffness requires further investigation. Outcome. Clinically used to improve LUTs, lower urinary tract symptoms, but additional antifibrotic or ECM modulating effects remain an active area of research. D. Rho kinase, ROCK, inhibitors. Rationale. Rho/ROCK signaling is central to cell contractility, stress fiber formation, and ECM remodeling. Increased matrix stiffness can drive Rho/ROCK activation in prostatic stromal cells, escalating mechanotransduction. Approach. Experimental ROCK inhibitors can reduce smooth muscle tone and may also decrease ECM deposition by altering myofibroblast contractility, although clinical translation in BPH is still early stage. 2. Mechanotransduction-directed therapies. A. FAK, focal adhesion kinase, inhibitors. Rationale. Focal adhesion kinase, FAK, is a key transducer of mechanical signals from integrins at the cell ECM interface. High ECM stiffness can lead to increased FAK activation and downstream signaling that promotes proliferation and fibrosis. Approach. Blocking FAK activation, pharmacologically or via genetic targeting, has shown promise in reducing fibrosis in other organs. Although not yet standard for BPH, it represents a novel avenue to dampen aberrant mechanotransduction. B. Integrin targeting therapies. Rationale. Integrins, e.g., alpha-5 beta-1, alpha-V beta-3, mediate cell adhesion to the ECM and are crucial in sensing matrix stiffness. Integrins signaling crosstalks with growth factor pathways, e.g., TGF-beta. Approach. Integrin-blocking antibodies or small molecule inhibitors can reduce myofibroblast activation and pathologic ECM remodeling. Again, these strategies remain investigational in BPH. 3. Regulation of ECM-degrading enzymes. A. Modulating MMP/TAMP balance. Rationale. Matrix metalloproteinases, MMPs, degrade ECM components, while tissue inhibitors of metalloproteinases, TIMPs, counterbalance MMPs. Dysregulation of MMP/TMP activity can lead to pathologic ECM accumulation. Approach: enhancing MMP activity, strategically increasing the activity of certain MMPs while avoiding excessive tissue damage can reduce excess collagen. Inhibiting specific TIMPs. If TMP overexpression is driving ECM buildup, selective inhibition might restore healthy remodeling. B. Antifibrotic peptides and growth factors. Rationale: agents such as hepatocyte growth factor, HGF, or decorin, a proteoglycan, can interfere with fibrotic signaling cascades, block TGF-beta binding, or enhance balanced ECM turnover. Outcome: early studies show promise in reversing prostatic fibrosis, but clinical use is still far in the future. 4. Lifestyle and physical interventions. A. Exercise and metabolic health. Rationale: while not directly targeting ECM stiffness in the prostate, overall metabolic health, e.g., insulin sensitivity, reduced systemic inflammation, can modulate fibrotic pathways and hormone levels. Outcome: regular exercise, weight management, and dietary measures can indirectly reduce the pro-fibrotic milieu, but these are supportive rather than primary interventions. B. Minimally invasive procedures. Prostatic stents or mechanical devices. Although these interventions focus mainly on relieving urethral compression, altering the local mechanical environment can secondarily affect mechanical stress within prostate tissue. Thermotherapy or laser treatments. Tissue ablation procedures, e.g., laser therapies, transurethral microwave thermotherapy, might disrupt local fibrotic areas, though the primary goal is usually volume reduction and symptomatic relief. 5. Future directions and considerations. Personalized medicine. As we learn more about the molecular drivers of ECM remodeling in BPH, targeted antifibrotic therapies could be tailored to each patient's specific pro-fibrotic signaling profile. Biomarkers of stiffness. Non-invasive imaging, e.g., elastography, or molecular biomarkers of ECM turnover, e.g., circulating MMP/TMP levels, collagen breakdown products, might help monitor disease progression and therapeutic response. Combination therapies. Blocking multiple pro-fibrotic and mechanotransduction pathways, e.g., TGF-beta plus integrin inhibition, may be more effective than single-agent therapy. Translational gaps. Much of the promising work on antifibrotic agents has been done in the context of liver, lung, or kidney fibrosis. Direct translation to BPH requires careful clinical trials, given the unique anatomy and hormone responsiveness of the prostate. Conclusion: managing ECM changes and tissue stiffness in BPH requires a multi-pronged strategy that integrates traditional therapies, e.g., 5-alpha-reductase inhibitors, PDE5 inhibitors, with emerging approaches that directly target mechanotransduction, e.g., ROCK, FAK, and integrin inhibitors, and fibrotic signaling, e.g., TGF-beta antagonists, MMP modulators. Although many of these novel therapies are still under investigation, they hold promise for more precisely modulating the prostatic stroma and alleviating the pathological remodeling that underlies disease progression.